nerves. I missed this. This looks important.
All right. So, Chapter 33, trauma to head, neck, and spine. All right. Nervous and skeletal systems. The nervous system controls thought, sensation, and motor functions. It has two subdivisions. The central nervous system consists of the brain and spinal cord. The peripheral nervous system consists of vertebral nerves, cranial nerves, and motor and sensory nerves. Neurons are specialized nerves that transmit nervous impulse throughout the body. Here we got a nice little drawing of that. One thing important that the nerves, we're going to go through some of them, some of the bigger ones. Luckily for us, it's not a requirement for the NREMT to know like every nerve. But it's good to know the difference between your central nervous system, your peripheral nervous system, and then we'll hit some other stuff in here. But you can kind of see that drawing and what it looks like. All right. Sensory nerves carry messages from the body to the brain. Motor nerves carry messages from the brain to the body. Motor messages control voluntary movement. Motor nerves cross to the opposite side of the body with the left brain controlling the right body. So keep that in mind. Nerves of the automatic nervous system control involuntary function. All right, anatomy of the head. The skull is made up of the cranium and facial bones. The cranium contains the frontal bone, parietal bones, temporal bones, and occipital bone. Facial bones include the mandible, maxilla, nasal bones, molars, and orbits. Most cranial and facial bones have immovable joints. The mandible joins the skull at the temporal bone. This forms the movable temporomandible joint. All right, the brain is held within the skull. The spinal cord exits the base of the brain and leaves the skull through the foramen magnum. Cerebral spinal fluid, also known as CSF, bathes the brain and circulates down the spine. All right, on this drawing, on the anatomy of it, we have all the bones we just talked about. So you have your if we start at the bottom down here. So the temporomandibular bone is our joint there. You guys can see it. You have it in your book too, I guess. The occipital bone, the temporal bone, your parietal bone, the frontal bone, and then this shows a suture, what it looks like together. Sphoid bone, nasal bone, lacrimal bone, the orbit, your vomer, and your maxilla, and then your mandible, and then you got your zygomatic bone, which is your cheeks. So, review those so that way at least you know where they are, know what they are. All right, anatomy of the spine. The spinal cord is a bundle of nervous tissue that extends from the brain stem to the small of the back. It is the main pathway for nerve messages. Spinal nerves branch out to carry messages. The cauda equina emerges from the end of the cord. The tough fibrous meninges surround the spinal cord inside of the spinal column. The spinal column is made up of 33 vertebrae. Vertebrae are stacked one on top of another and interlock. They are held together with ligaments and supported by back muscles. Every vertebrae has a donut hole that allows the spinal column to run through. All right, so vertebrae are divided into 5 areas. Have you guys covered the spine yet in anything?
Chapter 1 or 2.
I think it was right in the beginning. Anyways, so you've got your cervical, which is the group of 7 located in the neck. Then your thoracic is a group of 12, which ribs attach. Lumbar is a group of 5 in the mid-back. And then sacral is a group of 5 in the lower back. And then your coccygeal is the group of 4 located at your tailbone. So if you guys don't already know those 5 groups, it's a good idea just to know what they are and where they're at. So important, like cervical is 7, thoracic is 12, lumbar is 5. So that way if you go through and you have a question, you can narrow it down to which part of the back.
My professor in high school said breakfast at 7, lunch at 12, and dinner at 5. That's how I remember the
There you go.
7, 12, and 5.
So the sacral and coccygeal vertebrae are fused to form the posterior part of the pelvis. All vertebrae have a spinous process. And then here we got a little diagram of them. So like I said, at least know where they're at. Know that 7, 12, 5. And then, of course, you got your sacrum and your coccyx down below, down at the bottom. So they aren't too bad if you don't make it any harder than what it needs to be. All right, injuries to the spine and brain. So scalp injuries are where we're going to start. The scalp has many small blood vessels. Scalp injuries may bleed profusely. Control scalp bleeding with direct pressure. Dress as you would any other soft tissue injury. If there is a possible skull injury, use a loose gauze dressing instead of direct pressure. All right, next slide. Skull injuries. Skull injuries include facial and cranial injuries. Skull injuries may be open or closed. Open head injuries occur when the bones of the cranium are fractured. Closed head injuries occur when the scalp is lacerated but the cranium is intact. It is safest to assume open head injury beneath any contusion or laceration of the scalp. Always suspect spine injury with brain or skull injury. So if you have a brain or skull injury, you go in there with full spine immobilization. All right, here's a nice little picture of one. So we can see here that the skin is split, and you can see the bone, the cranium there, and the fact that it's got a good crack in it. So you got a little hole knocked in it. That's a good one. All right, brain injuries. Direct injuries occur with open head injuries. Brain is lacerated, punctured, or bruised by broken bones or by a foreign object. Indirect injuries occur with open or closed head injuries. Shock of impact on the skull is transferred to the brain. Includes concussions and contusions. All right, traumatic brain injury, also known as a TBI, disrupts the normal functioning of the brain and may be brief or long-term. Concussion occurs when the head is struck and the force is transferred to the brain. Should be taken seriously even with mild symptoms. Contusion is a bruised brain caused by a blow forceful enough to rupture blood vessels in the brain. Coup injury occurs on the side of the blow. Contra-coup injury occurs on the opposite side. So you have the injury where he got hit at, and then you got to remember that brain's floating around in there, right? You're going to have an injury on the other side too. Here we got a nice little diagram of what it looks like. So we have the blunt force in the front. So a concussion, mild injury, usually with no detectable brain damage, may have brief loss of consciousness. You have headache, grogginess, and short-term memory loss. A contusion is unconscious or decreased level of responsiveness and bruising of brain tissue. So that is the difference between the two. But we can see here what happens if we get a blunt force. What is the difference? What happens? So, and believe it or not, with doing football standbys, things like that, being as much sports as we have with young kids, this is not an uncommon thing for us to see and deal with. So, all right. Traumatic brain injuries, TBIs, disrupt the normal functioning of the brain and may be brief or long-term. Laceration is a cut to the brain caused by the same force that caused the contusion. Hematoma is a collection of blood within brain tissue. Subdural, blood collects between the brain and the dura. Epidural, blood collects between the dura and the skull. Intercerebral, blood pools within the brain. So you guys understand the difference between those three? Because these are all terminology that you are going to hear. So your subdural is blood between the brain and the dura. Epidural is blood collects between the dura and the skull. And then intercerebral, blood pools within the brain. So that's kind of going from outward in. Does that make sense?
Yes.
Okay. So here we can see on the diagram, so we got cranial hematomas, and we can see a subdural. So where that line there is the dura going around, it's kind of that protective coating. So a subdural is below it, it's sub. Epidural is between it and the brain and the skull, sorry. So between the dura and the brain, and then intercerebral, is in the brain itself. So, all right. As a hematoma develops, intracranial pressure, ICP, increases inside the skull. As ICP builds, brain tissue compresses and progressive neurological abnormalities develop. Rising ICP forces the brain toward the foramen magnum. The time it takes for symptoms to develop depends on the rate of bleeding in the skull. So this is one of those where, all right, so we're going to go through the next slide, I'll tell us. When the ICP increases, blood pressure increases to pump the blood into and perfuse the brain. The heart rate may slow in response to the blood pressure or due to vagus nerve compression. Rising blood pressure and slowing heart rate together is known as Cushing's reflex. That is a word you're going to need to know what it is. As ICP increases and perfusion decreases, carbon dioxide levels increase and brain tissue swells. As the hematoma grows and swelling worsens, the brainstem is compressed and breathing patterns change. Tachypnea, Cheyenne strokes breathing, central neurogenic hyperventilation, and ataxic respirations. As the brain herniates, how do you say that word? Dictorate or decerebrate posturing and neurogenic posturing may occur. Signs and symptoms of rising ICP may be immediate or delayed in onset. So this is one of those things, if you go to somebody with a brain injury, it's why we always get there, we get those baseline vitals. We ask them questions. We want to know how alert they are. We want to ask them who the president is, what day it is, what their name is. So that way, if you don't know them, you might not know that they are deteriorating. So we get that baseline as soon as we get there. If we have a bystander that knows them, and they're like, oh, my name's George. And they're like, no, his name's Mike. You know already that something is happening, or who is the president, or, what is, is Mickey Mouse a dog? Things like that. They're all funny questions and everything else, but to get a baseline, and you're not trying to trick somebody, you're trying to get a real baseline of where they're at. So when we talk about the patient assessment, signs and symptoms of skull fractures and brain injuries, visible bone fragments and brain tissue, pretty easy sign, right? Altered mental status, deep laceration or severe bruise or hematoma on the scalp or forehead, depression, deformity, or swelling of the skull, severe pain at the injury site, bruising behind the ear, also known as battle signs. Pupils are unequal or non-reactive to light. So a lot of those hit on that initial assessment we do, right? So we want to look for those things, though, if we know that we have. All right. We'll also get raccoon eyes, black eyes, or discoloration of soft tissue under both eyes. One eye could appear to be sunken. Blood or clear fluid flowing from the ears and nose. A personality change. Increasing blood pressure and decreased pulse rate, the Cushing's reflex. Irregular breathing patterns. Blurred or multiple image vision. Oops. Impaired hearing or ringing in the ears. Equilibrium problems. Forceful or projectile vomiting. Dictorate or decerebrate posturing. Paralysis or disability on one side of the body. Seizures. Temperature increase. Deteriorating vital signs. And then if there is shock with a head injury in adult patients, look for indications of blood loss elsewhere on the body. Assume skull or brain injury when MOI and location of the injury indicate a possible head injury. All right. Patient care. Take appropriate standard precautions. Consider possibility of spine injury. Open and maintain airway. Monitor the unconscious patient for changes in breathing. If indicated, apply a rigid cervical collar. Control bleeding. Keep the patient at rest. Talk to a conscious patient and provide emotional support. Dress and bandage open wounds and stabilize penetrating objects. Manage the patient for shock. Be prepared for vomiting. Transport the patient promptly. Monitor vital signs every 5 minutes en route to the hospital. All right. Glasgow Coma Score, GCS. Some agencies use the Glasgow Coma Score scale with AVPU for neurological assessments. Consider when using a GCS. So it is eye-opening, verbal response, orientated, confused, inappropriate words, incomprehensible sounds, no verbal response. Motor response, do they obey commands? Is localized as pain? Withdrawals after painful stimulation? Posturing after painful stimulation? No motor response to pain. Calculate the GCS score en route rather than spending time on scene. And then here is a nice little scale of the GCS. So eye-opening, so you get a score for everything. So for eye-opening, is it spontaneous? Is it to your voice? Is it to pain or none? So you would mark the appropriate box. Are we verbal? Are we orientated? Do we know where we're at? What's going on? Are we confused? Are we using inappropriate words? Are we making incomprehensible sounds or none?
Every ER we have, they have to do the Glasgow Coma scale on them, no matter if they're in trauma or non-trauma.
And we do it as well on our reporting for all of our patients. So we use this. You'll all be familiar with this when you start running. You'll need to be familiar with it now, but you'll continue. This is one of those things we continue to use. And then motor response, do they obey commands? Localizes pain, withdrawals from pain, flexion from pain, extension from pain, or none. So you total that up, and that kind of helps you find out what their score is. How bad are they? All right. Cranial injuries with impaled objects. Do not remove an impaled object. Stabilize it in place with a bulky dressing. If an impaled object is too long to transport the patient, pad around the object with bulky dressing, stabilize the object on both sides, cut with a tool that will not increase the object to move or to vibrate when it is severed. Seek advice for medical direction. That's where you're going to call your fire department, and we are going to get very creative. All right, injuries to the face and jaw. Facial fractures are usually caused by an impact. Be prepared to remove airway obstructions from the mouth and use suction. Treat the patient as for a suspected skull or brain injury. The mandible is subject to dislocation and fracture. Signs include pain, discoloration, swelling, and facial distortion. The patient may be unable to move the jaw, have difficulty speaking, and show improper tooth alignment. So if you think you have that, that's where you have them smile if they can. Are their teeth remotely lined up, or is their jaw way off? Sometimes if they're swollen, if they've taken a few punches to the face, it might be hard to tell until you see their teeth. And not that everybody has the best teeth, but you can usually tell if teeth are way offline. All right, when treating a facial or jaw injury, be prepared to suction to remove debris. Use the jaw thrust maneuver to open the airway if spinal injury is suspected. Control profuse bleeding. Consider the need for spinal immobilization. Position the patient to allow for drainage from the mouth and treat for shock. So how would we position the patient? On their side, right? Make sure if they're bleeding a lot, if they're having that it's not going down their airway. It's better to have it flowing out. If you notice, a lot of this sounds like a bar fight. Non-traumatic brain injuries. Many signs of brain injury may be considered by an internal brain event like a hemorrhage or blood clot. Signs or non-traumatic stroke differ from traumatic injury in that only one side is likely to be affected. So that is why we check, like our stroke scale, we're checking sides, we're doing those kinds of things because we can have those non-traumatic brain injuries. Wounds to the neck. Large arteries and veins close to the surface of the neck create a potential for serious bleeding. Pressure in large vein is lower than atmospheric pressure. The possibility of air being sucked in and causing an air embolism is great. The embolus can travel to the lungs and become a pulmonary air embolism. This can lead to cardiac arrest.
So specifically referring to the veins in the neck, so the jugular
Yes.
veins.
The jugular
They're
vein.
operating at negative pressure.
Yes.
That's new to me.
So it can suck air in, causing an air embolism. Direct pressure is a life-saving step in treating hemorrhage from neck wounds. First priority is stopping bleeding. Second priority is preventing an embolus, taking care to avoid interfering when breathing when applying pressure. So this is one of those kind of things where you don't just want to take your whole hand and slap it over, and you're going to want to be very careful with how you do that.
Isn't it that if there is a hole and you take it off, aren't you supposed to cover it?
If you what?
Like I don't know. I was lost my track of mind. You were talking about the
Negative air pressure.
how it sucks in. Aren't you supposed to put a
Gloved finger? Just
Yeah. You want to cover it, so you'd want to take, because you could, if somebody gets cut, you're probably not going to have up right there. It's probably going to be more than just that. And so you're going to want to cover the whole thing. But yes, sometimes your glove is the best protection, along with, you're going to want to have gauze or something there too to help hold it in. All right. Patient care. Ensure an open airway. Place a gloved hand over the wound. Apply an occlusive dressing. Place a dressing over the occlusive dressing. Apply pressure to stop the bleeding. Bandage the dressing in place. Immobilize the spine if the MOI suggests cervical injury. That answer your question?
me?
So here's an example of one. Looks like it sucks for that kid.
dog bite.
I would guess so. I don't know what else would do that. There's not much other trauma there, though. All right, injuries to the spine. Identifying potential spine and spinal cord injuries. When bone, ligaments, and cartilage of the spinal column are damaged, the spinal cord may also be damaged. Specific spinal column injuries. Fractures with or without bone displacement. Dislocations, muscular strains, disc injury including compression. These injuries can occur without cord damage, but the risk must always be taken into consideration. So you always want to err on the side of caution when it comes to possible spinal cord injuries. Last thing you want to do is have a guy that's walking and moving when you show up there, and by the time you're done with him, he's paralyzed. The spinal cord can be lacerated, contused, or impinged. Primary injuries occur immediately due to direct force. Secondary injuries occur after the initial insult. They can cause greater harm than primary injuries. They are not typically caused by damaged bone ends moving into the spinal cord as once thought. Hypoxia, shock, cord swelling, and hypoglycemia can lead to devastating cord damage. So keep that in mind. Assessment must account for the possibility of spinal involvement in any traumatic injury. Not every trauma patient has a spinal injury. Physical findings and MOI must be evaluated to make the appropriate decision about risk of spinal damage. Potential spinal injury identification must take both MOI and the patient's physical condition into account. The spine is most often injured by energy that forces the spine beyond its normal range of motion. So we have flexion or extension injuries, which is also known as whiplash. Over-rotation, so twisting sports injuries. Compression, like shallow water diving. Distraction injury, like a hanging. Penetrating trauma. Lateral bending or disc injury from improper lifting. Cervical and lumbar vertebrae are most susceptible to injury because they are not supported by other structures. Some medical conditions make the spine more vulnerable to injury. So osteoporosis in older adults, ligament laxity in pregnant women and patients with Down syndrome, fused vertebrae and fixed flexion deformities in ankylosing spondylitis, whatever that word is. Make it what you want, because I don't know. Some MOI have a high risk for spinal injury. Falls from greater than 1 meter or 3 feet or down more than 5 stairs. So that's our, right, if it's more than 3 feet or down more than 5 stairs. Axial loading, compression injuries such as those that occur in diving injuries. High-speed motor vehicle crashes, especially with rollover or ejection of patient. Motorized recreational vehicles, so ATV crashes. Bicycle collisions are another one. On our little drawing here, we have the star on the windshield, which we've talked about. We always want to look for. Diving injuries, so if they're diving into the shallow end of the pool. You have our whiplash, and we've talked about that before, right? You have your impact, and then you have your reaction. So that effect of those things happening. So maintain a high degree of suspicion for spine injury when your patient is a victim of motor vehicle or motorcycle collision, was struck by a vehicle, received a blunt injury to the spine or above the clavicle, was involved in a diving accident, was found hanging by the neck, was found unconscious from trauma. Some MOIs are low-risk mechanisms. Low-energy MOI pose a low threat of spinal injury. Penetrating trauma is low risk unless the trauma was to the spine itself. Spine fractures in the elderly are often caused by falls or spontaneous fractures of brittle bones. Consider how underlying factors like pre-existing conditions could make otherwise minor MOIs into serious threats. Many other mechanisms of injuries can cause spinal injuries. We good? Okay. Physical assessment for spine and spinal cord injuries. Mechanism alone does not identify injury. Assessment should specifically look for physical indicators of spinal injury. Pain and tenderness in the area of the spine are important findings. All right, relating spinal function injury. Damage to the spinal cord can isolate a part of the body from the brain, causing loss of function to a body region. A dermatome is an area of the body surface innervated by a single spinal nerve. This can be used to identify the loss of function at particular area of the cord. Additional key indicators of spinal injury. Paralysis of the extremities. It's pretty common, pretty easy one, right? Changes in neurological function. Pain with or without movement. Tenderness anywhere along the spine. Impaired breathing. Priapism, as we've talked, which is why you check when you do your head to toe. Loss of bowel or bladder control. Deformity. And then neurogenic shock. So we'll go back to those shocks. That's why you need to know the importance of the shocks. So patient assessment. Most algorithms used to identify the likelihood of spinal injury are based on nexus. The key elements of nexus. Is the patient reliable? Is there any pain or tenderness along the midline of the spine? Are there focal or neurological signs or symptoms? Is there a distracting injury or circumstance? What is the MOI in a pediatric patient? All right, the evolution of spinal care. Modern spinal care is based on thoughtful assessment and good decision making by the EMT. Rigid spinal immobilization can have negative side effects. Flat immobilization of patients with lung injury can be uncomfortable and deadly. Even short periods on a spine board can cause hypothermia and pressure sores. For any spinal injury, you must aggressively assure oxygenation and ventilation, actively treat severe bleeding, pay attention to blood glucose if capable. Primary assessment aims to identify potential for spinal injury and immediate interventions for hypoxia and shock. Treating hypoxia and shock is the same priority as spinal motion restriction. So you want to start those treatments immediately. Err on the side of caution and protect against broken bone ends even though the level of risk is unclear. Prevent movement of an unstable vertebrae by limiting movement of the entire spine. This is the basic principle of pre-hospital spinal care. Spinal motion restrictions prevent secondary cord damage by limiting the movement of individual vertebrae. The three centers of mass in the body are the head, shoulder girdle, and the pelvis. When these areas are prevented from moving, the spine generally remains stable. The spine has a natural S-shaped curve and is not a straight line. Spinal motion restriction accounts for this curvature. Vertebrae are maintained in a position of function that best represents their natural atomic position. This is known as an inline neutral position. Spinal mobile restriction of the cervical spine. Manual stabilization of the head is the first step in spinal mobile restriction. Manually restrict head movements by placing your hands on either side of the patient's head. Gently stop movement and maintain an inline neutral position. If the head is out of natural position, you can attempt to move it unless the patient complains of pain. So if their head is turned to the side and you try to align it and they start yelling that it hurts, don't move it. Hold it where it is. Okay? A collar wraps around the neck and provides a rigid form to help prevent movement. Collars must be properly sized. Collars must be applied in a way that does not obstruct the airway. Maintain manual stabilization even after the collar is in place until the patient is secured to the backboard. Once motion is restricted, establish a baseline for sensory, motor, and circulatory function in the extremities. All right, spinal motion restriction devices. Once the cervical spine is immobilized, the remainder of the spinal column's motion must be restricted. Ambulance stretchers are now considered padded backboards that provide appropriate spinal protection in combination with collars and straps. Rigid backboards are less commonly used today than in the past. Backboards are still used in some situations when transport time is short, when a big splint is needed for multiple injuries, when a patient will likely need CPR, when moving from a backboard to a stretcher is likely to cause excessive movements. Respiratory distress and conditions that impact breathing are contraindications for backboards. So remember that. Scoop stretchers are helpful for moving patients from the floor to the stretcher. Vacuum mattresses have the positive aspect of backboards but accommodate a natural anatomic position. They are hollow bags that allow air to be pumped out to create a rigid form. They are more comfortable than backboards. They can leak air and lose rigidity over time. They can rob heat from the patient. Following applications of any restrictive devices reassesses sensory and motor function in the extremities. All right, seated patient. There are two basic options for spinal motion restriction in a seated patient. Place a long spine board under the patient's buttocks and lower the patient to the board in a supine position. Have the patient self-extricate by standing and then sitting on the ambulance stretcher. Other seated extrication options are no longer recommended in the field, but may be tested on exams. Just so you know. If using a flexible extrication device or short spine board, secure the torso first and the head last. Special considerations when applying a short board. Assess the back, shoulder blades, arms, and collarbones before placing the device. The EMT applying the board must angle it to fit between the arms of the rescuer stabilizing the head. The uppermost holes must be level with the patient's shoulders. The base should not extend past the coccyx. Special considerations when applying it. Never place a chin cup or strap on the patient. Avoid applying the first torso strap too tightly. Some buckles have quick release mechanisms. Do not pad between the collar and the board. Only pad to fill an occipital void. Follow the manufacturer's instructions for the device and follow local protocols for vests or shortboards. All right. Applying a long backboard. So, log roll the patient to apply the backboard. Pad voids between the board and the head and torso. Secure the head last. Use foam-filled cushions, commercial devices, or blanket rolls to provide additional head immobilization. Tilt pregnant patients to the left after immobilization. Strap across the upper chest, pelvis, and thighs. If your service transports by helicopter, make sure the backboard fits. Use specialty backboards for water rescue that are designed to float up beneath the patient. For children 6 and under, pad beneath the shoulder blades to establish a neutral position for the head. Remember, your big old heads, little tiny bodies. Standing patient. All right, apply a cervical collar and have the patient carefully sit down on the stretcher. Guide the patient into a supine or semi-sitting position on the stretcher. The stretcher straps will secure the patient and help limit movement. Here's a diagram showing the EMT in the back is holding C-spine in a neutral position. EMT in the front is applying a cervical collar. Now on the next slide, it shows them sitting down, and then what you would do is you would assist that patient in turning. One would help their legs, one would help their back, and you're going to turn that patient and either lay them or sit them up, depending on what's needed. All right, for a patient wearing a helmet, face, neck, and spine care and airway management or resuscitation may require helmet removal. If the helmet is left on, lift shields and remove guards. Why is that?
So you can
Obviously, you can.
So you can
They
see
said
them,
they have an
right?
airway?
So you can see them. If the airway is intact, do not attempt to remove a helmet if doing so causes pain or the helmet is difficult to remove. When to leave a helmet in place. It fits snugly, allowing little or no movement. There are absolutely no airway or breathing issues. Removal would cause further injury. Proper spinal immobilization can be done with the helmet in place. It does not interfere with the EMT's ability to assess airway or breathing. It interferes with the EMT's ability to assess and when to remove a helmet. It interferes with the EMT's ability to assess and manage the airway. It is improperly fitted. So if you have a 5-year-old wearing an adult's helmet and it's just all loose and flopping around, take it off. It's not doing any good. It interferes with immobilization. Cardiac arrest is present. If an athlete is wearing shoulder pads and a helmet, either remove both or remove neither. If a helmet must be removed, use a two-rescuer approach. Chapter review. All right. The two main divisions of the nervous system are the central nervous system and peripheral nervous system. You should maintain a high index of suspicion for head or spine injuries whenever there is a relevant mechanism of injury, MOI. You must provide cervical spinal motion restriction before beginning any other patient care when head or injury spine is suspected. Altered mental status is an early and important indicator of head injury. Monitor and document your patient's mental status throughout the call. A traumatic brain injury is an injury that disrupts function of the brain and may include anything from a slight concussion to a severe hematoma. Always secure the torso to the backboard before the head. Remember, the key components of the nervous system are the brain and the spinal cord. These organs regulate thought, sensation, and motor functions. The skull vertebrae and cerebral spinal fluid efficiently protect the brain and spinal cord. In a closed head injury, the skull remains intact. This is dangerous because the skull is a closed container with little room for bleeding or swelling. Neck wounds are at risk for massive bleeding and air entry, causing emboli. The spine is injured most often by compression or excessive flexion, by extension or rotation from falls, by diving injury, and by motor vehicle collisions. These injuries can interrupt nervous system control of the bodily functions. Inline immobilization of 33 spinal bones is the essential component of spinal injury immobilization. Specific procedures apply to different immobilization and extrication situations. EMTs should be proficient in handling the basics of these procedures. Questions to consider. Does my patient have a mechanism of injury that would indicate the need for spinal immobilization? Do my patient's potential head or spine injuries require prompt transport to a trauma center? All right, some critical thinking. You are treating a patient with a head injury. He has an altered mental status and a significant MOI to the head. Your partner thinks you should hyperventilate. When should you hyperventilate? What are the signs and symptoms that would indicate this is necessary? Is this that Cushing's thing we were just
I was
talking
going to
about?
say, if blood pressure goes up, pulse rate goes down, you want to hyperventilate, right? Get more carbon dioxide build up in there.
You want to get the carbon dioxide buildup. Yeah, you want to get it out, push it out.
Out, sorry.
Yep. But there's your Cushing's. All right, that is the end of that one.